Good morning. I'm Kevin Downs from the Children's Hospital of Philadelphia. Thanks so much for the opportunity to speak on clinical applications of microsampling. I'm sorry I can't be there in person. If you have any questions, please feel free to reach out by email or on Twitter. You've already heard today about some potential research and clinical applications of microsampling. So I'm going to provide a little bit broader of an overview in how this newer technology might be utilized. I'm a pediatric infectious disease physician and a clinical pharmacologist, so I'm going to focus mostly on therapeutic drug monitoring, which is an avenue where I think microsampling really has an opportunity to improve clinical care of patients. And in doing so, I'd also like to highlight some of the challenges to implementation of microsampling in a clinical setting. And then we're going to discuss with specific examples, both in the inpatient and outpatient setting, future avenues for use of microsampling technologies. An area where I feel microsampling holds promise to greatly improve the clinical care of patients is in the field of therapeutic drug monitoring, or TDM, which is the practice of measuring drug concentrations to inform drug dosing in individual patients. The goal is to maximize efficacy and minimize toxicity in that individual. Traditional TDM involves collection of a single sample at a specified time point and interpretation of the resulting drug concentration within the concept of a therapeutic window. If the drug concentration is too high, then the patient's felt to be at risk of toxicity. If the concentration is too low, then the patient's at risk of drug failure. And so the drug doses are adjusted in order to move the drug concentration up or down in order to achieve this therapeutic target. But this is a non-sophisticated way to adjust doses and provides very little information about the individual patient. And so model-informed precision dosing, or MIPD, has been developed to leverage more information about how drugs behave in populations and in individuals. MIPD utilizes complex statistical and mathematical models along with individual patient information such as drug concentrations and organ function markers in order to understand how the drug is behaving in that individual. And with this approach, MIPD is able to provide tailored and targeted drug therapy in individual patients. Whether we're talking about traditional TDM or MIPD, there are generally three criteria that are thought of as being required for use of therapeutic drug monitoring. The first is that a drug should have a known toxicity threshold, such that too much drug is going to result in toxicity. A drug should have a known efficacy target, so we know how much drug to give to be effective. And lastly, there should be large interpatient variability in the drug concentrations that are achieved for a given dose, such that you can't reliably predict what a concentration would be just by knowing the dose alone. And when these three criteria are met, it's typically felt that a drug would be a good candidate for TDM. But relatively few drugs are actually subject to therapeutic drug monitoring. When it comes to decisions about which drugs should be monitored, toxicity generally rules the day. Shown here in green are the drugs that are routinely monitored in pediatrics, and a common denominator is that each of them is associated with notable toxicities. But I would argue that therapeutic drug monitoring has an opportunity to improve both the efficacy and minimize the toxicity of many medications. I think there are many drugs within these red groups that could benefit from therapeutic drug monitoring and targeted therapy in children. Unfortunately, the performance of TDM that is truly informative on drug dosing is not easily accomplished. And this is for a variety of reasons. Many of the reasons that have to do with the way that our samples are collected. First of all, people don't like needles. As shown in the figure here, a fear of needles by age, not only do most children fear needles, but a substantial portion of adults are also needle phobic. And so traditional venipuncture by phlebotomy is not a task that's easily performed. And this leads to difficulty in obtaining appropriately timed samples. The data that are shown here display the percentage of correctly timed vancomycin trough levels in a large cohort study of nearly 800 patients. And as you can see, that fewer than 60% of these samples were actually collected at the appropriate time. And when it comes to children, this is even more difficult because kids are small, and so they have small veins, which means that phlebotomists need to be highly trained in order to collect blood from such small veins. But additionally, their blood volumes are limited, and so we need to be very cognizant about how often and how much blood is collected when we're thinking about therapeutic drug monitoring. And so there are multiple advantages to the use of microsampling over traditional phlebotomy techniques. For one, as the name implies, microsampling involves collection of small volumes of blood, microliters of blood, which is ideal for patients with limited blood volume, such as infants, so we don't run the risk of anemia. Secondly, most microsamples are collected using capillary sticks, which is far less invasive than venipuncture, and it promotes the collection of multiple or repeated samples for drugs that perhaps might be area under the curve-based drugs. Additionally, because capillary sticks can be performed at precise times, they can be more informative and therefore leveraged for use with population PK models and MIPD. Additionally, this less invasive and more informative sample collection can be optimal in patients who have difficult access, such as those with burns or who are obese or have clotting and bleeding risks. Lastly, microsamples are dried before they're analyzed, and this process of drying increases their stability from hours to days, such that many samples can be collected and shipped through the mail without compromising analyte integrity. And so microsamples are also optimal for drugs that are used in the outpatient setting because they can promote home and remote monitoring. And so I wanted to spend a few minutes discussing a variety of approaches that are available for microsampling. Dried blood spots are the most well-studied microsampling approach, but have some significant limitations when it comes to quantification of drug concentrations. First of all, the sample variability can be high due to hematocrit effects. As you might imagine, the viscosity of the blood can differ based on the hematocrit, which will impact the size of the spot and the sample volume that's utilized. Similarly, inhomogeneity within the sample and uneven analyte distribution can impact the results depending on where the punch is made within the dried blood spot. And so, although these have been well studied and validated for many drugs, and there are techniques available to overcome some of these limitations, these can be challenging samples to deal with. Volumetric absorptive microsampling, or VAMS, is a newer technique that overcomes many of the limitations of dried blood spot sampling. VAMS involves collection of a fixed volume of homogeneous blood, most often from a capillary stick, that can be used for quantification of drugs. As shown here, there are several devices that are available for the performance of VAMS sampling. Unfortunately, because these devices are all slightly different, laboratory methods for the development and validation of assays are device and drug specific. Ultimately, there are important advantages of VAMS over dried blood spots for therapeutic drug monitoring. As mentioned, VAMS are designed to collect a fixed volume of homogeneous blood that is independent of a patient's hematocrit. This allows for reliable and accurate quantifications of drugs. Additionally, many of these devices are designed to be collected by patients, and so they are relatively easy to use, and in fact can also often be collected just by an individual person. While there are many benefits, it's also important to recognize the current challenges to microsampling for therapeutic drug monitoring. First, samples have to dry. Although this period can be as short as 1 to 3 hours, some analytes require a longer drying time. And when combined with current methods for drug quantification that utilize LC-MS, there can be a significant period of time between collection and the availability of results. And so clinical scenarios that do not require rapid turnaround time are best suited for microsampling currently. As a result, most VAMS devices are actually devised for outpatient use. And analytical methods that are being developed and validated must be specific to both the device and the drug. As mentioned earlier, the devices each differ slightly in their specifications, and so you cannot reliably translate one VAMS result to another. And similarly, clinical validation studies are necessary for every drug and device, and so careful thought needs to be given to the type of device that's used and the analyte that's being measured. And I would encourage the development of multiplex assays that will greatly improve the workflow when trying to implement microsampling for TDM. And this is again because analytical methods are so specific that we want to try to leverage multiple samples that can be measured at a time. Lastly, even though microsampling devices are patient-centric, they're not always easy to use. We performed a pilot study of critically ill children prescribed vancomycin and sought to evaluate the relationship between capillary blood concentrations and plasma concentrations. We collect paired capillary blood samples using the Mitra devices, which are shown in the top right, and plasma via standard TDM approaches. And of 31 capillary and venous arterial paired blood samples, 16% were unavailable due to improper loading of the VAMS devices. This is because there are very specific methods for collection of the blood, and although we provided instruction to bedside nurses, there were still challenges in the collection process. So you can imagine that when patients are performing these samples, there may be additional challenges, and so performance of very clear and precise instructions is extremely important. So I've highlighted some areas where microsampling can help advance the field of therapeutic drug monitoring and discuss challenges to implementation of microsampling in the clinical setting. Now I want to discuss a few avenues in which our team is looking to utilize microsampling to advance the care of pediatric patients. The first area is antibiotic TDM. As mentioned earlier, relatively few medications are subject to therapeutic drug monitoring in children. And when it comes to antibiotics, only aminoglycosides and vancomycin are routinely monitored. But beta-lactams are the most commonly prescribed antibiotics in children, and mounting data suggests that target attainment is infrequent when it comes to beta-lactam concentrations in critically ill children. And so we're performing the AMPLE study, which is a multi-center study that seeks to understand the relationship between early antibiotic PK and multi-organ dysfunction syndrome in critically ill children. And we've partnered with the Pharmacokinetic and Mass Spectrometry Core Lab at the University of Michigan, run by Drs. Amit Pai and Bo Wen, to develop assays for quantification of vancomycin in the most commonly prescribed beta-lactam antibiotics using volumetric absorptive microsampling. And the lab is currently developing a multiplex assay that will allow for measurement of each drug from a single sample. And what we hope to do through AMPLE is develop population PK models for each drug using VAMS that can then be translated into a microsampling-based approach for model-informed precision dosing. So through our partnership with the PK Core Lab at Michigan, we'll have a method to reliably and accurately quantify all of these antibiotics in children and ultimately improve empiric antibiotic dosing and early target attainment in critically ill kids. An additional avenue of translational research for our lab has to do with immunosuppressant TDM in pediatric transplant recipients. You already heard an excellent talk from Dr. Lino about the clinical applications of microsampling for immunosuppressant TDM. And in pediatric solid organ transplant recipients, immunosuppressant TDM is not only vital, but is also extremely onerous and intrusive. In a study out of Switzerland that looked at therapeutic drug monitoring of pediatric liver and kidney transplant recipients, the mean number of tacrolimus levels drawn in the first month post-transplant was more than 20 per patient, and in months 2 through 6 after transplant was more than 13 samples drawn per patient. So microsampling holds great promise to improve the care of pediatric transplant recipients who require frequent therapeutic drug monitoring in the first months after their transplant. So we're performing a study called MAIDEN, which seeks to develop and validate assays for quantification of tacrolimus, sirolimus, and cyclosporin using VAMP samples. This study was originally developed and designed by Drs. Ganesh Murthy and Athena Zupa, and is now being conducted under the guidance of Dr. Stephen Master, and the clinical validation study is being performed by my team. But there are additional opportunities to utilize microsampling to benefit pediatric transplant recipients as well. Cytomegalovirus, or CMV, is a major cause of morbidity and mortality in pediatric solid organ transplant recipients, and the most common preventative strategy is to use antiviral prophylaxis, usually with valganciclovir. At our hospital, 60% of solid organ transplant recipients receive prophylaxis in the first year following transplant. And in a study that we conducted, receipt of valganciclovir prophylaxis was associated with an increased risk of neutropenia of more than 4-fold and of kidney injury of nearly double compared to patients who did not receive valganciclovir prophylaxis. And unfortunately, the optimal dosing strategy for valganciclovir in pediatric solid organ transplant has not been established, with some centers providing weight-based dosing and others providing body surface area-based dosing. But despite its known toxicities and lack of established dosing, valganciclovir TDM is rarely performed in pediatric transplant recipients. This is because it's an area under the curve-based drug, which means that multiple samples would have to be collected in order to accurately estimate the AUC. And although a therapeutic range has been established in adults, it's unknown if this should be the therapeutic target for children. In a study of 23 transplant recipients less than 4 years of age, the area under the curve, estimated using 2 levels, one drawn at 2 hours and 5 hours, reasonably approximated the area under the curve from 4 levels. And so it's possible that valganciclovir TDM could be performed with limited sampling. But a trough sample or a single sample is unlikely to be fully informative. And so microsampling may be an ideal approach to valganciclovir TDM in children, and it's an avenue that we're currently investigating. The advantages of microsampling in this setting is that it can be performed remotely, and since multiple samples would need to be collected, it can also be used to collect samples at specific times. And there are several reports of accurate and sensitive ganciclovir quantification in dried plasma and blood spots, and so we're looking into the utility of VAM sampling for valganciclovir TDM. Lastly, microsampling doesn't have to be limited to therapeutic drug monitoring applications. Microsampling approaches can also be used for diagnostic and monitoring purposes. Microsamples have been used for quantification of serum creatinine, as well as screening of various infections such as SARS-CoV-2 and hepatitis C. In fact, dried blood spots have been shown to have a high sensitivity for screening of congenital CMV infection, and have also been shown to have a good correlation and moderate sensitivity when it comes to CMV quantitation compared to plasma. And so microsampling might be an optimal method for monitoring of CMV itself in pediatric transplant recipients. And we're partnering with our infectious disease diagnostic laboratory to look at the use of VAMs for monitoring of CMV in our transplant population. In conclusion, microsampling can improve the care of patients requiring frequent, repeated, and/or precisely timed sampling for TDM. It's a patient-centric approach that's less invasive than traditional phlebotomy and involves collection of much smaller sample volumes that allows performance of TDM in even our smallest of patients. Laboratory and clinical validation studies are needed for each drug and device of interest, but multiplex assays may help create a more feasible and practical workflow for implementation in clinical laboratories. I want to thank Dr. Parker and the University of Queensland for the invitation to present today. I also want to acknowledge my mentors and collaborators both at CHOP and outside of our institution. In particular, I want to thank Athena Zupa, who introduced me to the field of microsampling and has been a significant mentor of mine. Additionally, I want to thank my research team that's shown in the bottom left, who's really helping to move forward our studies, as well as our funders and collaborative networks. Thank you.